Hey everyone, Robert Riley here to discuss the recently released calcium treatment algorithm in the SCAI consensus document on treating calcified coronary lesions. When you look at the main figure from that document, where it goes through sort of identification and treatment, you really start with identification of these lesions. And usually, when you're in the cath lab and you're looking at your angiogram, you start by seeing that there's significant calcium in the arterial beds prior to dye being injected. You really know it's significant if you see calcium on both sides of the vessel. That's going to indicate your moderate or severe calcified beds. Then the next step is ideally using intravascular imaging to identify both where and the type of calcium that you have, because both are going to dictate how we treat that vessel. It's important to look for the three main characteristics that indicate you need to treat some type of calcium modification solution, which is going to be your arc, so how much of the donut is actually full of calcium, the length, so how long, being over 5 millimeters being significant, or the thickness, being over 0.5 millimeter. Now, not everybody uses OCT, which is really the best way to get thickness, but IVUS can definitely show you that. It can show you whether it's that thin rim or do you get a lot of dropout behind it, showing that it is thick. After you've identified those, the question becomes, well, first, could you get the catheter down to begin with, or can you get anything else across? If not, then that's going to be your wire across gear won't go. So I've looked at my angiogram, I said, oh, there's a lot of calcium there, but my imaging catheter won't go. Well, that usually means other things won't go, and that's going to be a time on the left side of that figure where you really got to use atherectomy. Really, there's very little else out there at that point for sort of wire across gear won't go, as they say. So that's where you use atherectomy in order to get a pilot hole. It's still really important to image after that, because you will not see cracks the whole way, and those cracks indicate that we're starting to get some change in compliance, and that we can use NC balloons after that in order to get the vessel prepped and ready for stent implantation. But often, particularly in the more proximal areas of the vessels where it's larger, you won't see that, and that's where you can still utilize intravascular lithotripsy in order to get more of that modification, and that's that idea of rotoshock. Let's say you can get your imaging catheter across, and we don't see those three criteria, the arc, the length, and the thickness that are important. We still recommend using NC balloons in order to make sure you get 1-to-1 size with 1-to-1 expansion, and you get a good full expansion in 2 views, making sure that you don't get it foreshortened in something else and you're missing it in another view. If you do get that good full expansion, you move on with the PCI, and there you go. But if you don't, then you shift to that right side, and that right side is where you've either not had the criteria but your NC balloons still won't go, or, I actually do have those criteria of a length greater than 5 millimeters, a thickness greater than 0.5, or a big full circle of calcium there, a big arc. And that's where you're going to have to start using some type of calcium modification tool. Now, we tried not to be too proscriptive about which type to use in which situation, because again, there's not as much head-to-head data. What do we know? Well, we know that for nodules, atherectomy doesn't seem to lower major adverse event rates. IVL has been showing promise there, so I think IVL is important there. There's still the idea that we could do rotoshock for that, so atherectomy first to shave the top off, IVL second. Now, what about for concentric calcium? Well, IVL obviously really shines there. Short lesions, could you use specialty balloons? Sure, you can. I think the studies showing that you have to go up to really high pressures dissuades a lot of people from that, whereas IVL, really there's low pressure, right? So you're not going to get mechanical disruption, perfs, etc. So I think IVL really shines there. And then your long diffuse lesions, that's going to be a little bit of dealer's choice. Now with C2+, you can treat long lesions with that. But if you're going to really fight it, getting it down, that's where atherectomy can really be helpful. But again, remembering to still test with NC balloons after, still use intravascular imaging after to make sure you have the cracks before you're set up and ready to implant your stents.